All right, and I will introduce our presenter today, who is Dr. Roger Lewis. He is a senior medical scientist at Berry Consultants and a professor of emergency medicine at the David Geffen School of Medicine at UCLA, among many other roles. Roger is also a senior statistical editor for JAMA and was a faculty member of the CTMC for many years. So we're so grateful to see him today and look forward to his presentation, which is titled Surviving Peer Review, a Perspective on the Review and Reporting of Results from Randomized Clinical Trials. I'll turn it over to you, Roger. Thank you.
Great. Thank you so much. It's a pleasure to be here. And I'm going to assume that you can see my slides. Okay.
Yep, looks great.
Okay. So what I'm going to do today is give a presentation related to how manuscripts reporting the results of randomized trials are reviewed at JAMA. I'm obviously doing this from my role as the senior statistical editor at JAMA, and sort of try to tie the way we think about threats to validity in clinical trials to the reporting to try to help you avoid some pitfalls that authors sometimes run into. My email address is there. I'm easy to find. Feel free to email me with questions, and I will do my best to leave time for questions at the end in discussion. These are my disclosures. The most important one here is that I have this editorial role at JAMA and work as a consultant in clinical trial design. So JAMA's the lead journal of the JAMA Network, which is published by the American Medical Association. It's a weekly journal, which does have a lot of implications for how it runs internally. We get lots of submission, over 10,000 submissions of all article types. Overall, 12% are accepted, but of the over 5,000 annual submissions of research manuscripts, the overall acceptance rate is about 5%. So it's a selective journal. The reason the acceptance rate is higher overall is because that includes a lot of things like editorials or clinical reviews that are solicited manuscripts. About half of the research publications we publish are clinical trials. The other half are observational, other types of research work. So the goal of peer review is to determine whether a manuscript should be published in the target journal. And that's primarily based on the journal editorial staff's impression of the importance and impact, the scientific quality and rigor, and the clarity, balance, and transparency in reporting. And all three of these are different characteristics that are actively considered in making an editorial decision. I'll just say for immediately that the peer reviews, the reviewer comments you get address all of these. They're specifically helpful in assessing the first two. But if one is overly optimistic in one's interpretation of data, overreaches, there seems to be a lack of transparency in reporting things, that definitely works against one. The peer review of manuscripts is roughly divided into two broad categories. The content reviewers are those experts in the field and in which the clinical trial is placed, that address the importance, the gap that the research is addressing, the impact of the results on clinical practice or the scientific direction in the field, and whether the presentation is balanced and appropriate. Separate from that, there's methodologic review, which focuses on trial design, the integrity, and especially the fidelity of the reporting to the original design, data quality, analysis, statistical interpretation. The methodologic review is largely focused on trying to figure out whether or not there are threats to validity. Are the numbers that you're reporting, are the conclusions you're drawing firmly based in the data? And I'm going to focus on the methodologic review. So obviously, the complete, rigorous, balanced, and transparent reporting of results from clinical trials is a fundamental piece of high-quality evidence generation. Journals want very much to support that. I think that's a very broad statement across all journals. And the key components that influence the validity of an RCT are the appropriateness and integrity of the statistical design. So what you started with, how you actually implemented the study, and then the final analysis. Now, there are things that you can do from the very beginning, like taking the course and working on your protocol, through the drafting of the manuscript that can either improve or adversely affect your likelihood of being able to be published in the journal of your choice. And that's what I'm going to try to focus on. So many journals have a separate statistical review process that supplements the content review. And that's, again, what I'm going to focus on. So this was a paper done many years ago. Steve Goodman is an extremely well-known methodologist up at Stanford, and they simply looked at what journals did. And what they found was that about a third of journals rarely use statistical reviewers. And I will say that this is generally a lower tier of journal where they rely on their peer reviewers in the content area to comment on methodologic issues. About a third used it for some of their articles, and a quarter, and I would guess it's now probably closer to a third or a half, use it for all articles. They just routinely send out the articles for methodologic review at the same time that they are reviewed in content. So this is our review process. When you submit a manuscript, it's reviewed initially by a senior and associate editor, and approximately half, in our case, two-thirds, are returned without review. So that's called a desk reject. And whereas it's very depressing to get your manuscript bounced back to you so fast that you didn't even get a chance to take a breath, this is actually intended to be a service to the authors. And the reason it's a service is to allow you to immediately resubmit your manuscript somewhere else where it's more likely to get published so you don't have an unnecessary delay in getting your results out. Often this is because the topic of the article is just not appropriate for the journal. For example, JAMA is a general medical journal. If you have something that's only going to be of interest to subspecialists in your area, or is very technical and not of general medical interest, for example, it may be returned without review, even if it's of very high quality. If it is sent for peer review, it's sent to both content reviewers, plural, and to a statistical reviewer simultaneously. When those reviews come back, if they're not sufficiently supportive, it will be rejected after review, but then you'll get comments back that will help you improve it. I will say one of the most important lessons to learn is that if your article is rejected and you get comments back, do not immediately submit the same article to somewhere else, but actually try to revise it in response to those comments that you think are thought out. Give yourself some time to get over the emotional response so you actually can judge which ones are worth responding to. It is incredibly common for it to be sent by the next journal to some of the same reviewers that reviewed it the first time. The world is pretty small. And one of the most damning things you can get back at your second journal is the person saying, I reviewed this previously for another journal and they haven't changed anything. Okay, you want to avoid getting that comment. If the reviews are sufficiently supportive, it's discussed at a manuscript meeting. Our process is that twice a week, for a couple of hours each time, we go through all of the manuscripts that have received sufficiently supportive reviews and make decisions about requesting revisions or rejection. That meeting often involves 20 or 25 people with wide ranges of expertise. So it's a group decision. Again, the peer reviewers do not make decisions, they provide input. It is common for manuscripts to be rejected after all three reviewers thought they should be published, often because they were overly enthusiastic about something in their field. It is also very common for articles to be sent back for revision with the intent to ultimately publish when one of the reviewers said it should absolutely be rejected, and there are lots of reasons for that. When it comes back, when you submit a revision, it's reviewed by an associate editor to see whether you answered everything, and it seems like you've been able to successfully address the concerns that are raised. At that point, an editorial decision is made, and usually We do not send it out for peer review again, but very occasionally we do an internal review to make sure that the authors have really addressed the most pertinent of the concerns. When you submit a revision, the first thing most editors do is they go through everything they asked you to do and make sure you didn't leave anything unaddressed and that you made a good faith effort to be as compliant as possible. I know in medical studies we're supposed to use the word adherent because compliance intends a certain yielding to the will of others. Here I mean compliant. Okay, the intent is to put your ego aside and to take advantage of the wisdom that has hopefully come through in the review. Okay. Sometimes we ask for another revision. We try very much not to do that to delay publication. Most often when we do that, it's because there's been something that's been unaddressed. Okay. Now it is fine to say I'm not going to do something, but then you need to have a good reason um, rather than it being one of personal preference or style. Okay. We have a lot of statistical reviewers. We maintain a cohort of statistical reviewers. The reason we do that is so we have expertise across a broad range of methodologic areas and that we um, uh, and that they're sort of calibrated into what we're looking for. In neurology, Valerie Drolkowski-Modlett at MUSC is one of the reviewers who typically will review clinical trials in neurology, but there's a number of people who can do that. Okay. All right. Here are the things that come up. The issues that come up are in trial design, specifically the degree of pre-specification. Was it really clear you had a plan for exactly how you were going to run the trial? Trial conduct, were you actually able to do what you said you were going to do? Obviously, there are areas that are going to be challenging, like patients being lost to follow-up with long longitudinal studies, adherence to intended treatments if the treatments are burdensome. The data analysis, was there a complete pre-specified analysis plan, especially of the primary and any secondary endpoints? And then did you actually follow it? If you didn't follow it, do you explain why it was you couldn't do what you originally planned? We originally planned to do a logistic regression model, but that didn't converge, so we had to do something else. That's fine, but you can't leave it unaddressed why there was a change. And then is the presentation balanced? And one of the things we look at is the ordering and selection of results to emphasize. So when you write your protocol, there's a set of primary and secondary endpoints with a specific order. The ordering of the secondary endpoints should reflect their relative importance. And then you want to report them in exactly that order, not whether they're positive or negative. It's very common for authors to want to present all their positive stuff with lots of words and then very briefly mention that there was some other stuff that was negative. You have to maintain that order because it's part of the pre-specified hierarchy of the results. We also look for selective reference to trends that are non-statistically significant. You can't pick out just some of your non-significant results to say, hey, that looked promising because you liked the direction. You have to stick to the pre-specified analysis. Okay. So why do we care so much about pre-specified analysis? So I'm going to digress for a second into a little bit of sort of thinking about causal effects to explain why we care so much. So if you think about the data that you collect, there's multiple things that impact the patient outcomes. So just think about the primary outcome of your trial. So there's the patient characteristics, think of their baseline illness severity, and just idiosyncratic things that affect their outcome. The treatment that you administer, hopefully that has some effect on the outcome of interest. And then there's just this random variability, just stuff happens. All three of those things affect individual patient outcomes, and data or the treatment effect, I should call it the treatment effect, and random variation look the same in the data set. You don't know if someone survived because the treatment helped them or they were lucky. You don't know if someone died because the treatment didn't work or they were unlucky. Both of those things can affect outcomes. When you analyze the data, you don't make decisions about your analysis strategy based on the data themselves. All you do is transfer the data and then they are subjected to that analysis. So you take your data set, you run the code. In pharmaceutical trials that are intended for FDA review, the code analyzing the data is written long before the data are ever available. So it's completely pre-specified. The code is the code. This is how I'm going to analyze the data. Okay. And that gives you your study results. The reason we care that the analytic strategies and the decisions to be made in analysis are pre-specified is because if instead you don't have a pre-specified analysis, then the data themselves can impact the analytic strategy. So this is where you run a model, you adjust for several different covariates, baseline illness severity, gender, site, for example, and you just miss statistical significance. And you think to yourself, God, I really thought this was going to work. And you think, oh my God, if I only also adjusted for something else, for the baseline 6-minute walk number, I could get a positive result. You do that, and then suddenly it's positive. That seems like you may have uncovered the signal from the noise, but what's really happened is you've created a way for random variation to influence the analytic strategy and therefore the results. So what that does is it creates a pathway where you can introduce bias because random variation creates patterns in the data that you then sort of chase in the pursuit of a statistically significant or positive result, and that gives you a biased result. So a lot of peer review is focused on making sure that that didn't happen, that the analysis was pre-specified and the data themselves, however they turned out, didn't influence the analysis strategy directly or indirectly. And the reason creates bias is because your goals aren't random. Investigators don't search around for the analysis that gives a negative result. They search around for the analysis that gives a positive result. Okay. So what happens in the life of an actual clinical trial? So in an actual clinical trial, you spend a lot of time working on your trial concept and developing your initial protocol and your statistical analysis plan. And all of that is pre-specified and becomes captured in your trial registration. Please do not enroll a first patient in a trial without registering your trial. And for US-based investigators, that should be at clinicaltrials.gov. Then what really happens is that, oh, my slide didn't do what I expected. Oh, I'm sorry. I did change this. The purpose of trial registration is not the pre-specification of the trial. The purpose of trial registration is to make sure that other people working in the same area of the field don't duplicate work, or patients who are looking for trials can see the full range of trials that might be available to them. And what you don't want to do is run your trial and then try to register it retrospectively, because that doesn't give people a heads up for what's available to them while you're running your trial. Okay? That's trial registration. What I was trying to get to was that once you start running your trial, a lot of stuff happens. There may be some administrative data that tells you your number of sites was not enough. There's external data someone else publishes in the field and shows that one of the doses you were testing is not safe or is not effective. There may be changes in priorities or resources. All of those things may lead to amendments to your protocol or your statistical analysis plan, and maybe even updating your trial registration. As long as those things are not influenced by the data within the trial, separated by treatment group, so not influenced by whether your outcome is different by treatment group, those things are not biasing. So they're fine. You just want to document what you've changed and why, maintain an electronic paper trail. The only exception here is that the Data Safety Monitoring Board, which typically has access to unblinded data where they can look at outcomes separated by treatment group, their recommendations are are potentially biasing. So the DSMB needs to not be trying to chase random highs or random lows. Their recommendations need to be based on maintaining the ethical balance and scientific integrity of the study. So that's why DSMBs need to be scientifically uninterested in the outcome of your trial, although they need to have the necessary expertise to monitor the trial. Okay? So all of these amendments are fine in terms of maintaining pre-specification, even though they occur after first patient in. You just have to make sure they're documented. Okay. So this is another way of looking at some of the same things. So one of the first threats to validity we look for is bias from design decisions or changing that were informed by knowledge of differences by treatment group. And the reason that's a problem is because if the analysis strategy follows the data, you tend to follow noise. And then what's even more dangerous is if there's a loop where you look at the results and then you change your analysis. I want to point out that this is incredibly common in observational studies where people get the data set, they start to analyze it, and they modify their analysis informed by what the prior analysis showed. That is inherently a biased approach to determining treatment effects, which is why observational studies are largely seen as hypothesis generating and only under special circumstances can have a causal interpretation. Another source of bias is what we'll call multiplicities, which simply means doing things multiple times. But the most dangerous of these is hidden multiplicities, where the reviewer or ultimately the reader of the article can't tell that there were multiple analyses. So picture a setting where your primary analysis gives a non-significant result. So the significant result would be a treatment effect to the right of the dashed line, and you get something that misses statistical significance. This is the very unpleasant situation where you have a trend in the direction you wanted, but it's a negative trial. But if you analyze it a second way, or you find even a third way, often with different models or treatment of missing data in different ways, you can get a positive result. You want to report, obviously, the pre-specified analysis, and those other analyses probably should not be reported at all or reported as post hoc exploratory analyses. But what you never want to do is write your manuscript as if analysis 3 was the only one you did. And the way journals try to detect this, and believe me, this happens, is they look for the consistency of the report with the initial statistical analysis plan or the last statistical analysis plan that is dated prior to the data becoming available to the investigators for analysis. Okay. The other thing that happens, which is sort of a modification of this, is selective reporting or selective emphasis, where, for example, here, consider a trial where you had one primary endpoint and two secondary endpoints that were ordered number 1 and number 2. So notice I used the exact same graphic to make the point that this is the same issue. Sometimes when this happens and the primary is negative but the secondaries are positive, the reporting is written as if the second secondary endpoint was really the first, and that was the thing that was most important. So you'll see in the abstract of the article a lot of language around the one thing that was positive and maybe no mention at all or just a mention in passing that the primary endpoint was negative. You can't do this because it's a kind of spin. And I will tell you at selective journals, it decreases the level of interest in the manuscript. Okay. So journals look at consistency of trial documents, and I want to spend a few minutes talking about the different trial documents and where we look for the different pieces and why it's so important that you maintain each of these and with version control. So you submit your manuscript, which reports your eligibility criteria, how you randomize the treatments, and then the results for the primary, secondary, exploratory endpoints. You also, in your statistical analysis section, have the analysis models and maybe what your plan was in terms of interim analysis. But in addition to that, you need to submit to the journal the study protocol itself And I've bolded the things that I personally look to the study protocol to be the gold standard, if you will. So if there's an inconsistency in the primary and secondary endpoints, say for example in their exact definition or in their ordering between the study protocol and the manuscript, I assume the study protocol is the source of truth and the manuscript has been um, written in a way to try to emphasize a message the author wishes was supportive, but it's potentially biased. You also should submit a statistical analysis plan. For all but the most simple studies, it should be a separate document with much more detail than would go into the study protocol. And that's where I look for again, the primary and secondary endpoints, and it needs to match the study protocol and the manuscript. And then I look at how the analysis was going to proceed for the exploratory endpoints, the actual analytic methods, and any plans for interim analyses and stopping rules, especially early for either success or futility. But in addition, you may have published a design manuscript that laid out your initial plans for the trial. Now, notice that I don't use that as some sort of source of truth for what the trial is you should ultimately report, because the design publication often occurs long before all that stuff happened in the middle of the trial that made you change things as it was going. But it does tell us what your initial motivation was, and it tells us your initial plans, and we should understand when we look through all these documents how the plan for the trial and its actual conduct and analysis evolved over time in response to various events or considerations. It is problematic when the initial design publication says our intent was to, you know, demonstrate that this treatment changed this outcome in this population, and the manuscript is totally different. We want to know why that happened. And then there's also the trial registration, which is also a useful indicator of the initial plans. Do try to keep your trial registration up to date if you make major protocol amendments so that it is an accurate reflection of where you ended up as well. And then there's the DSMB charter. If you have a data safety monitoring board especially that's involved in implementing interim analysis plans, for example, for early stopping, you want to make sure that that charter is consistent with the interim analysis plan in the SAP and as reported in the manuscript. So we look at all of these things for consistency, and it often gives a very clear picture of how the trial evolved over time and whether it was done in a way that maintained the scientific integrity of the trial. Even at a very selective journal, you'd be amazed how often we get a manuscript that is written as if the study protocol or the SAP was just an initial thought and not the final word, and when in fact it should be exactly the opposite. Okay. And then lastly, this just to remind me to mention that the consort diagram is often intended or is primarily intended to make sure you report everything in the manuscript and to make sure that any patients who are lost to follow-up are appropriately accounted for. Okay. So the overarching issues in terms of self-inflicted injuries is, as I've now emphasized probably ad nauseum, inconsistency across the study documents and the manuscript, especially in the definition and ordering and analysis of endpoints. Version control issues. Sometimes we'll get a manuscript where the manuscript is submitted on, September 1st, and the SAP is dated August 31st of the same year. And it looks like they looked at the data and then decided how to analyze it and then wrote an SAP or updated it. That's a bit of a red flag. And then failure to include all the elements required by reporting guidelines, especially lost follow-up, how missing data are handled, were tabulated, and handled. Now, what I've done in this slide presentation is I've actually gone through each of these areas of design, study conduct, analysis, reporting, and laid out things that go wrong. Rather than sort of read these to you, What I'm going to ask is Megan to provide the slide set to everybody. I hope that's okay. Okay.
Yeah, happy to.
And then you can look at it. And then uh, but I'm happy to take any questions or go back to this for specific questions. But lastly, I'd just like to say there are things that we like to see when they're done well and appropriate. So there's no problems with using modern approaches to trial design, which includes basket trials, platform trials, um, adaptive trials, factorial trials that look at two different treatments simultaneously, say 2 by 2 factorial trials, cluster randomized pragmatic trials, Bayesian methods. All of those things are fine as long as these basic issues of pre-specification and adherence to the plan, unless explained otherwise, is maintained. So let me stop there. I'm going to stop sharing, and I'd be happy to take any questions, or if people want, I could go through the detailed slides, but I thought it was better just to make those available for you. I will stop there.
Thanks so much, Roger. If people have questions, you are welcome to put it in the chat, or you can raise your hand, unmute, and ask it out loud.
And I'm also happy to address questions of the type, I got this back from a journal, what should I have done?
This is Doug Postles. I don't know how to raise my hand, sorry, but is it okay if I just speak up?
Yeah, that'd be
Please.
great.
Yeah, I'm the PI of a investigational new drug for cerebral malaria that we're doing in Malawi. It's a drug that was developed by NIND, and we're conducting a phase 1/2A study.
Hmm.
Just the study, the drug was first trialed in adults, and we recently published that, and we're currently enrolling children,
Hmm.
which is our target population. Our primary endpoint is safety. Obviously, it's a phase 1 study. We have some uh, secondary endpoints related to neuroimaging, et cetera.
Hmm.
But my question for you is that our DSMB unblinded the data after the first half of participants were enrolled, and we have a huge difference in mortality risk between the children who received drug and the children who received placebo. This is adjunctive therapy.
Hmm.
Um, Are we not supposed to tell people about that in our primary manuscript? The like we're enrolling the second cohort, the second half of the participants, but
How
we
large is the sample size?
it's about 100 and it will be about 160.
Okay.
Um, and currently
And
the difference in mortality risk um, is very large. It's 25% in the placebo group, which is the standard, and versus 3.6% in the drug group.
okay.
So,
And the um for the children with cerebral malaria, I assume there's some sort of baseline measure of illness severity that gives you a predicted mortality risk.
right.
And did that appear relatively balanced in the two groups?
Yeah, in the
Yeah.
interim analysis,
Yeah.
yes.
Yeah. So in any trial of a disease that has potential mortality, people expect mortality to be reported.
Okay.
Even if your trial didn't say mortality is a secondary endpoint or an exploratory endpoint, we would, because it's obviously such a central outcome for patients with life-threatening illness. So the way I would suggest, and let me just understand one more piece. When you say they unblinded it halfway through, you mean they let you know before your planned sample size for the phase 1/2A trial, um, while you were still enrolling, they let you know that the mortality difference was large?
Yes, they did.
Okay. And when they did that, what was their motivation? What did they want you to do? What was their recommendation for trial conduct?
I don't know. I'm not on the DSMV.
Okay. Um, all right. So usually when a DSMB makes data available, they're supposed to include a specific recommendation for what they want you to do with it. Remember, they're the ones who are supposed to not only have the insights associated with having knowledge of unblinded data, they're also supposed to be um, without scientific or financial or intellectual conflicts of interest, and therefore they're supposed to give recommendations um, intended to maintain the ethical balance and the integrity of your trial. So in this setting, I would have hoped they said, but we think you should continue the trial, or we think you should
Yes,
stop the control. Did they just say you should continue the trial?
correct.
Okay. Well, that puts you in a very difficult situation because the obvious question is it still ethical to randomize to the control therapy? I assume the drug is not approved and available in the population, so most children with cerebral malaria will not have access to it. Is that correct?
Correct.
Okay. All right. The contrast, just so people understand where I'm going, is that if it was a repurposed drug that's commonly available in the setting, then I would worry about that those in the trial are being disadvantaged because some are being randomized to control, whereas children not in the trial would have universal access to the drug. That's why I asked that question. Um, so this is a very difficult situation. And how quickly are you enrolling?
Well, we're not enrolling right now because of the NIH, to be
Oh, okay.
completely honest,
Okay.
because we have no money and, it's a foreign country, so it's not,
Got it. Okay. Okay.
we're trying to overcome those barriers now.
Okay. That is, boy, what a question to start with. Um, Obviously, I don't know the details of your situation. My inclination, because this is not it's not a small phase one. Sometimes we see phase one trials, that have a dozen people or 2 dozen people. This is a relatively large phase one, 2A study. It's not as if it's a surprise that mortality is important in pediatric cerebral malaria. What I would recommend is that you write, and especially since you've been forced by external events to terminate enrollment or suspend enrollment, I would write up the report now and report the mortality outcome. This puts you in a very difficult position regarding the further investigation of the drug because the question becomes one of how do you proceed with drug development should the political winds change and you be able to continue it or funding from the becomes available elsewhere. Is the drug company is not in a position to finance further work?
Uh, Let me clarify, please. The stopping of enrollment due to financial situations, we believe is temporary and we'll get our funding and we'll be able to continue and finish the trial as planned. Um, and there is no drug company.
Okay.
Um,
What is the
it's
intervention?
it is a small molecule that is a glutaminase inhibitor,
Okay.
stops the
Okay.
conversion of glutamine to glutamate.
Okay. Yeah. I guess it depends on how long you think the gap is. If you think the gap is going to be weeks or a couple of months, then I think continuing the trial, if you can finish it in a reasonable amount of time, which I would say is something like a year, then I think that's probably a better path. If you thought that the funding stop was permanent, then I think you write it up and report it. The thing that I'm concerned about is where you go next. So what does your late phase two or phase two, three look like trying to get registration or marketing authorization in Europe? Um, and I wonder if this is in a setting where you can actually uh, use an uncontrolled on treatment single arm trial for the next phase of development. Because if the result is so striking, if you can enroll a significantly sick population of children with cerebral malaria and the mortality is 5%-ish, maybe it's just so obvious that it's making a difference that you don't need a control arm. Because I'm trying to figure out
Yeah.
your consent process going forward, saying We think this cut the mortality in factor of 5. We have the drug at this site, which is why we're doing the trial, but I want you to accept a 50% chance that your child ends up on control. That's a very difficult consent discussion. Um, and
Oh, agreed. Agreed.
there are considerations about whether cerebral malaria is an orphan disease or a rare disease that also come into this in terms of the regulatory pathway. Anyway, it's a fascinating question, incredibly important work.
Yeah,
Um,
sorry to hit you
no,
with a hard one first
no,
off.
no, it's no, it's I love thinking about these things. It's a very challenging thing. Um, uh, yeah, when you write it up, I know there are a lot of journals that would be interested in it.
Yeah, don't send it to JAMA, not general medicine. Got it.
No, 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 that's not what actually that's not what I meant. So I'm not here to solicit articles, but I will tell you that's the kind of thing that JAMA would be interested in because general medical interest doesn't mean you treat the patients. It means the disease is important, and I think everybody knows that malaria is important. It's just like any general. If you had a positive trial in Ebola, everybody would want to publish it, not because we all expect to see Ebola tomorrow.
Got
So
it. Appreciate
interest
your
is not
time.
the same as practice. Okay, happy to take any other questions.
I don't know if anybody can top that question. God, that was really a lot to think about.
Yeah, but very cool. Makes me wish I was at your course this year.
Well, Doug wasn't at our course this
Oh,
year. I think, Doug, you were there in the past. Is that right? Or am I mixed up?
I have. I was enrolled in this course several years ago and I loved it.
Yeah, you were in Ann Arbor. You were working at the
I
Gates
was.
Foundation then?
I was, and it was a really amazing experience. And after that course, I did a phase 3 study. I was sort of the second in command of that in cerebral malaria. And then we started this trial about 6 years ago. I'm the PI. So you guys did
wow.
it.
Congratulations. Congratulations to us. Oh, and you.
Fill out your tracking outcome survey, please.
Yeah.
Well, okay.
Um, Good morning. Yeah, I have a question. Thank you so
Great.
much for the wonderful talk. I have a question. So, can I have your input on statistical analysis approach in general for outcomes that are not binary?
Hmm.
And traditionally, yes or no event, clinical events, it's easier for me to understand the statistical approach. But for my study, I'm trying to monitor a cerebral blood flow at the
Hmm.
baseline and then during the stimulation. And at the baseline, I'll monitor the TCD blood flow essentially, for example, 5 minutes. If the heart rate is 60 per minute, I'll have 300 number as a like mean blood flow velocity at the baseline. So
Hmm.
300 numbers. And
Hmm.
during stimulation, I'll have another 300 numbers of flow during the stimulation.
Hmm.
So then, usually I thought the approach would be compare baseline versus stimulation.
Hmm.
I'll have a mean of these 300 number then at the baseline and then mean of these 300 number at during the stimulation. So
Hmm.
that's one approach me and my statistical support plan to do. But I'm wondering, is there any other way to look at these numbers? Because, for example, during the baseline, there's minor variation, and then during the simulation, there may be more fluctuation of these numbers. I just feel like get a mean of these um, over these 5 minutes doesn't reflect the full hemodynamic change. For example, um, I guess I want to say, is there any other ways to look at these numbers
Hmm.
rather than just give a mean here and a mean here and do a paired t-test?
Yeah. So yeah, you don't want to do a paired t-test. So the standard approach for that is something called a mixed model for repeated measures. So the way a mixed model for repeated measures works, and the term mixed means that some of the predictors of the outcome are fixed effects, meaning they have a given effect, and some are random effects, which means on average they have a certain effect. It's sort of a technical distinction. But the thing that a mixed model for repeated measures can do is handling the clustering of your numbers within patient. So the structure of your data is that the first 300 numbers are all from one patient. Then you change the condition on that patient and you get 300 new numbers. Each one of those numbers is a data point, but they are not independent from each other. They're all clustered within the patient. So if I have a particular cerebral blood flow by TCD in baseline, the next number you get from me is likely to be more similar to my prior number than a number that you get from someone else in the baseline condition. So the mixed model for repeated measures handles that properly. So without that last piece you threw in there, which is that the variability is increased in the is as a stimulation. Okay. So the fact that the variability increases in the stimulation is a little bit of a challenge. I'll get to that in just a second. But the first answer to your question is it's a mixed model for repeated measures, full stop. And your statistical consultant should know how to do that. It's a very, very standard approach. The fact that the variability increases in the stimulation period is a bit of an inconvenience because there's an assumption within the model that the variability is sort of the same. The way to address that is with a transformation of the data. So for example, if you take your blood flow, and I gather in stimulation from the way your hand moved, the blood flow goes up. Then what you can do is you can take, for example, the log or the square root of the blood pressure and actually analyze the data on that transformed characteristic. And what that does is it makes the variability more similar in the two settings. So for example, if the blood flow doubled and the variability went up by 50%, it turns out that's exactly a square root transformation. It's a very common situation. So your statistician should be able to look at your data and see whether transforming it can make the variability of the transformed variable the same in the two periods. And then you can directly use the mixed model for repeated measures on the transformed data, and that will analyze your data properly. But you're absolutely right. You do not want to just do a mean and a t-test. That would obscure some of the information in your data, not be a correct analysis.
Okay, great. Thank you so much.
Okay.
I have to re-listen your summary and then
Yeah.
discuss with sounds like very complicated, but thank you so much. Yeah.
Yeah, you might want to just play that little soundbite for your
Mhm.
statistician. And hopefully you'll get nodding and not a perplexed look.
Thank you.
Okay.
Thanks, Sunny, for that great question. We have time for another question if anyone has anything. I'll ask a question if no one else has. The research landscape is shifting in so many ways and so many things. And do you have thoughts? Has that changed the way you review and evaluate manuscripts at all, or do you anticipate how it would change?
Well, I think when you say the research landscape,
It's harder.
I'm sorry.
I guess it's harder to get funding. The types of research that people want to fund has shifted over the past 2 years or longer.
Okay. Yeah, if you're talking about political pressures on research, especially, I think that all journals are understanding that people have had abrupt changes in research plans due to external forces and are much more accepting of that. And, the goal is to make the best possible use of the information available to us. And when the information is limited because of external forces, I think people are realistic. The key to submitting articles and the way we're reviewed is being transparent and stuff. So if you didn't reach your sample size because you were doing work on health disparities in an underserved population, and your funding suddenly disappeared, then you just have to say what happened. And journals should work with you to try to make the best use of the information that was collected. I'll just make a point from an ethical perspective. It is a breach of our agreement, our compact, our interactions with human participants in our studies if we fail to use the information that they provided. You know, when people enroll in trials, a big part of their motivation is to contribute to the world being a better place for them or for others. A surprising number of patients enroll in trials without any expectation that it will help them, but simply to help others. It's a very altruistic thing. So we need to honor that by making use of the information they provide, even if we're forced by external circumstances to do so in a way that's different than the original plans. I also think that as funding is harder to get, there is a greater understanding of the need for trial design and implementation approaches that are more pragmatic, using, for example, data collection from the EHR as opposed to individual CRFs, basically things to reduce the burden of conduct of trials. Again, the key here is that you've planned to do it that way and you have some measure of the quality of the information that you're acquiring. I will say one thing that always pains me is when people collect lots and lots of data elements that they are never going to be able to fit into a manuscript and slave over those on each individual participant. So I always urge people to try to be more parsimonious of what they collect. And of course, the reason you do that is because you worry that, oh, but what if I need the 12th blood pressure on the third day? And with experience, you find you just never need the 12th blood pressure on the third day, and you just shouldn't collect it. But I know that's sometimes hard for people to feel comfortable with during the design. So try to be more parsimonious in the data that you collect. Try to honor our agreement with the people who put themselves at risk to participate in our trials, or our research studies of various sorts, and be transparent with journals about what happened. Those are the things that come to mind.
Thank you so much. Heidi, did you have a question?
I do have a question if we have time. So thinking about thank you so much for that awesome talk. Thinking about being on the reviewer or editor side for journals that don't have this level of rigorous statistical review embedded in the process, I'm curious if you have suggestions, for example, when the clinicians here on the call are the clinical peer reviewer and something feels fishy about the statistics, and also from the perspective of someone who's an associate editor at a journal that just has one statistical editor that you ask for, on demand or in special circumstances. If you have any suggestions for how we can recruit and find these folks to do the statistical review or to provide input, even, as people are writing their manuscripts, from that kind of perspective, because that expertise is, I think it's harder to come by in some ways for many people in their environment.
Yeah, well, it was a multifaceted question. Thank you, Heidi. So I'm going to try to, I think, work backwards from a second. So in terms of people writing manuscripts, the care and feeding of your longitudinal relationship with your statistician is really important. So it's just critically important to get a statistician at any level involved early on and keep them involved in your study, and try really hard to give them credit and give them opportunities to, present research when appropriate, because you want to foster that relationship. Because if you have a statistical colleague who's working with you in the long term, not only do they learn your field and get better at it, but they help make sure that your trial has the integrity we've been talking about. On the journal side, I think you can go a long ways when you're reviewing a manuscript to just pull up the protocol and the SAP as you're reviewing it and just seeing if everything lines up, even without tremendous statistical expertise. Because a lot of what we look for is just this consistency. And if that consistency is lacking, especially analyses that were planned that are not reported, or the analyses that are reported are different than those are planned, I think that's when you as a reviewer say, this just seems odd. They plan to do this, they're now doing this other thing. Why is that? And just flag it for the editor. The editor has to decide if they have the ability to get the necessary bandwidth and statistical expertise within the editorial process to follow up on all those things. But as a reviewer, at least you can point them out. I think that editors probably universally appreciate that, because it is a nightmare for an editor to publish an article and then have a letter come in that says, oh, by the way, this is clearly wrong, or they clearly buried the negative result. So I think just focusing on that consistency doesn't require statistical expertise. It just requires the willingness to do that. One of the editorial folks that I worked with for a long time had three displays on his computer screen in front of him, and he would pull up the manuscript on the center one, put the protocol to the left and the SAP to the right. And as he went through the manuscript, he would just always scroll to the corresponding piece in the protocol and the SAP while he was reading the methods or results. And he would never read one without the others there. And this was just his personal workflow for making sure that consistency existed. I probably missed a piece of your.
Oh, I think that's great. As far as recruiting statistical reviewers, that was the other.
Everybody is trying to recruit them because there's a lack of it. There's a lack of the sufficient bandwidth in many settings. I think the key here is investment. And what I mean by that is try to foster longitudinal relationships with junior people for whom it's good for their career, their academic promotion, and the like, and make sure they're full partners. I think a lot of statisticians feel that they're brought in once there's a problem or later on in the process, and they're not being treated like scientific colleagues, but like technicians. And, when you don't have money to pay people, respect goes a long way. So my advice is to try to find people, work with them when they're more junior than you might have hoped, and then foster a longitudinal relationship.
Thank you so much. Thanks everyone for your questions, and thanks Roger for a great presentation. We will be posting the recording and can send out the slides, and hope you all have a great day.
Great. Thank you so much, everyone.
Thank you, Roger.
Okay.